Good evening, everybody. Today I'm presenting a case of a rare and successful management of pediatric Lyme injury during the COVID pandemic. Oculochemical burns are an acute ophthalmic emergency, alkalis being the more common agent at 60% of total oculochemical burns, commonest being Lyme. Amongst the pediatric oculochemical injuries, the most common mode is bursting of tuna packets. Alkalis are more dangerous owing to the mechanism of action where they penetrate deeper into the stroma. Here we have a case of a 3-year-old female child who presented to the OPD with a right eye redness, pain, and watering since 7 days with a history of right eye accidental fall of line while playing with the tuna packet. There was history of consultation at a local clinic where she was given primary management in the form of ocular lavage and was subsequently referred. On presentation, patient had right eye vision at PLPR defective, and there was 180-degree limbal blanching with superior 1/3 deep stromal infiltration or deposit. Adjacent 2.5 to 3 mm of sclera also showed infiltration or deposit with Adua's grade 4 ocular burns. We took the patient for an urgent lamellar dissection with glycerol-preserved donor CS rim, which was the only available tissue during the first wave of COVID pandemic. Patch graft and AMG was done under general anesthesia. On the top right image, as we can see, there was a chalky white substance in the superior 1/3 of cornea and sclera, which was dissected, revealing an underlying healthy DM and endothelium complex. Histology was suggestive of dried up tissue with fibrotic stroma and calcification, suggestive of Lyme deposits. Culture was negative. A graft was fashioned custom to the defect and sutured, and a double-layered AMG was done over the graft with fibrin glue. Corneoscleral infiltration post-ocular Lyme injury is a rare presentation with a likely diagnosis of retained Lyme particles. Present case was managed timely by debridement, glycerol-preserved CS graft, and AMG to enable future visual rehabilitation. At 8 months of follow-up, the patient had visual acuity which improved to counting finger 1 meter with vascularized CS graft with superior mild symblepharon with chances of future visual rehabilitation. After 12 months of primary surgery, cadaveric simple limbal epithelial transplantation was performed, and post-op day 15 of which there was visual acuity which improved to counting finger 3 meters. During the COVID pandemic, there was a delayed time of presentation of the affected patients, explaining the late presentation in the present case. In time where eye donations were far and few, timely use of available resources like a glycerol-preserved CS graft in conjunction with AMG preserved the tectonicity and provided therapeutic purpose where visual rehabilitation could be planned. Timely management in cases of a chemical injury is critical. Immediate intervention in forms of lavage, debridement, AMT, tenonplasty can exponentially increase the chances of visual rehabilitation. In a meta-analytical study conducted by Clifton et al., it was seen that patients with timely surgical intervention were found to have greater visual acuity, shorter epithelial defect diameters on follow-up, greater reduction in limbal ischemia, and possibly preventing the need for a future slit. In a study conducted in Western India, it was also noted that there was significant visual improvement and corneal vascularization was to a lesser extent, which encouraged performance of an AMT in early phase. Take-home messages are, even in times where fresh corneas were not available, use of techniques like AMGs and tectonic grafts from glycerol-preserved donors can provide a good emergency alternative. Chemical injuries, especially Lyme, are fairly common and necessitate a timely management, which can often be site-severe. A proper primary management is critical and should be undertaken even in absence of facilities. A lavage, proper debridement, and timely intervention can protect patient prognosis. Examination of pediatric patient can be especially challenging, owing to lack of cooperation. Should always be done with double eversion, and GA or sedation should be considered. Thank you. These are my references.
Thank you. And wonderful done surgery. COVID was a difficult time for us. We were struggling with corneal tissue, and at our center also we used glycerin tissue a lot of time. And that was the right approach. Whenever there is tuna particle, you have to remove it. If you don't remove it, the eye will go into thysis bulbi because of the slow release, and continuous inflammation. And so final was finger count half meter, you said, right?
3 meters, sir. So actually, we do not have, the patient has not come after the final follow-up.
Anyway, at times we feel that 3/60 is not a good vision, but if you see the outcome of chemical injury patients, right, 3/60 is still a good job. Right, because we have seen patients' eyes going to thysis bulbi. The injury was severe, as I can see. So in this patient, the chances of thysis bulbi is quite high. Perfectly managed cases. Now, any comment from the panelists?
When was the patient lost to follow-up? Patient? Like
so
now or there, I mean, just
at
after the
15
surgery?
days, the last follow-up we had was 15 days post-SLET, which was counting finger 3 meter, as I mentioned. After that, patient has been lost to follow-up and has not yet come.
So I just wanted to ask you the, the current age, but then you're saying the patient,
Patient was
because
lost
you
to
have to
follow-up.
manage amblyopia also in such patients. And you have used the terminology of infiltrate. I don't think that's correct. Superior corneoscleral deposits. Infiltrate means infective, right?
Yes, yes, ma'am. Actually, we were suspecting, we couldn't, that's why we even
Infection.
went for histopathological examination of the deposit. So we wanted to rule out any infective etiology.
I think your patient might be doing good only. That's why he has
Yeah.
lost to follow.
So the patient might be doing good. So
Let's
this is a
do-
good, valid explanation.
Do we have Dr. Vanshika?